All right, this is chapter 15. This should be the last lecture for the course. Management of patient and personnel radiation dose during diagnostic X-ray procedures. We can reduce exposure by limiting the patient's exposure to ionizing radiation by employing appropriate radiation reduction techniques, using protective devices that minimize radiation exposure. Patient exposure can be substantially reduced by use of proper body and body part immobilization, motion reduction techniques, appropriate beam limitation devices, adequate filtration of the X-ray beam, use of gonadal or specific area of shielding, selection of suitable technique exposure factors used in conjunction with computer-generated digital imaging, use of appropriate digital imaging processing, and elimination of repeat radiographic exposures. Importance of instruction. Clear, concise instructions should be given to patients. Good communication can reduce anxiety and stress. If you know what you're about to do will cause pain or discomfort, emphasize that with the patient. Some repeat exposures can be attributed to poor communication. Immobilization. Blurred images will need a repeat exposure, so immobilization is important. Two types of patient motion are voluntary and involuntary. What are examples of each motion? What are ways we can control these types of motions? So voluntary motion is when the patient physically, consciously moves. Involuntary motion would be like Tourette's syndrome, where someone has like a tic, or peristalsis. Protective shielding. Protective shielding is very important in radiation protection. Areas that should be shielded when possible include the lens of the eye, breasts, thyroids, reproductive organs. Gonadal protection. Adequate collimation is the first step in gonadal protection. Gonadal shielding should be applied in useful beam if it's within 5 centimeters or 2 inches of the reproductive organs. The shield should be positioned directly over reproductive organs. Types of gonadal shielding. The following 4 basic types of gonadal shielding devices are flat contact shields, shadow shields, shaped contact shields, clear lead shields. Flat contact shields made of lead, usually 1 millimeter thick, set directly over reproductive organs. Useful in AP or PA protections with patient recumbent. If used during fluoro, should be placed under patient to be effective. Shadow shield, suspended above the patient, cast a shadow over patient reproductive organs, useful in a sterile field situation, not useful in fluoro due to moving beam. Shaped contact shields, contain 1 millimeter of lead, enclose male reproductive organs, looks like an athletic supporter. Since it is the shaped shield, any position will provide good gonadal protection. Clear lead shields, transparent lead devices. Have you seen these and where? So most of these are usually seen in surgery or like at Texas Children's, where the parents are standing behind them so they can watch their kids. Exposure factors. Choose the correct exposure factor. This is important to getting a diagnostic image with minimal patient dose. Several ways to do so. Use standardized technique charts. Use high GVP and low mass. Repeat images. Repeat images are images that must be performed more than once because of error. Patient skin or gonads may receive double dose. This will always be an increase in patient dose. Be sure to correctly position patients and select appropriate techniques. Some hospitals utilize a repeat analysis program. Reasons for unacceptable images include patient mispositioning, incorrect centering of the radiographic beam, patient motion during the radiographic exposure, incorrect collimation of the radiographic beam, presence of external foreign bodies, post-processing artifacts. Amount of radiation received by a patient from a procedure. There's 3 ways to identify this. Entrance scan exposure, ESE, very important. Widely used in assessing radiation received to patients. Bone marrow dose, average dose to entire active bone marrow. Gonadal dose. Since genetic effects can arise from exposure, this dose is of particular concern. Fluoroscopic guided positioning, FGP. Defined as using fluoroscopy to determine the exact location of the central ray before taking a radiographic exposure. ARC defines this as an unethical device. Studies indicate that the dose increases when FGP is used. ARC statement on this position and ART Code of Ethics basically state that technologists should not use FGP to position patients. Pregnant patients. Embryo fetus is very radiation sensitive. Reasons we ask pregnancy questions: if unsure, pregnancy tests or explanation of risks and benefits should be given. A female patient of childbearing age should be given a shield. Sometimes we x-ray a patient and they turn out to be pregnant. Pregnant patient, embryo fetus is very radiation sensitive. Reason we ask for pregnancy questions: if unsure, pregnancy test or explanation of risk and benefits should be given. All female patients of childbearing age should be given a shield. Sometimes we x-ray a patient and they turn out to be pregnant. Information needed to develop the request for patient radiation dose form. The x-ray unit are units used for the study. The projections taken, the number of images associated with each exam. Each projection's technical exposure factors, KVP, mass, image, receptor size. The source to image, receptor distance, the SIDs for each projection. The patient's anterior, posterior, AP, or lateral dimensions at the site of each projection. For fluoroscopic irradiation, the appropriate KVP, mass, and especially the duration. For spot films, the number taken, the KVP and the mass selected, and the appropriate exposure time. Dose reporting of embryo fetus. When information is collected, RSL responsibility to determine the absorbed equivalent dose to the embryo fetus. Again, usually we talk about effective dose. In this case, we're talking about equivalent dose for embryo fetus. This result is an estimate dose received and is given to patient's physician. Pediatric considerations. Remember, children are more vulnerable to effects of radiation. Children require smaller doses. Due to patient motion, cooperation is important during procedures. Make sure that we have gonadal shielding and that we call a mate. Let's talk about personnel protection. So, dose limits. Federal government standards follow the NCRP recommendations of 50 millisieverts. If a LARA is followed, no radiographer should reach that limit. It only refers to occupational received doses and not personnel medical exposure. It's 10 millisieverts times age. For a lifetime effective dose, limits again in millisieverts. A LARA concept. As low as reasonably achievable. That's the acronym. Applying the principle of time, distance, and shielding, adequately collimating the radiographic beam. Avoid repeat imaging. We use a conservative relationship between ionizing radiation and potential risk. Again, that's the straight line LNT, linear non-threshold model. Patient as the source. During procedures, the patient becomes a source of scatter radiation. If needed, should stand at 90-degree angles to the patient. Scatter poses the greatest risk to occupational exposure. What are ways that we can reduce scatter? So again, stand at 90 degrees from the patient. So those of you who work as a tech aide, try to stand on the side of the patient, not directly in front of the image receptor when holding. Protective apparel. So here's that acrylic lead barrier. Should wear at all times when needed to be in the exam room. These both are examples of protective shielding. Another example are leaded gloves. 0.25 millimeters lead is minimum requirement. Again, 0.25 millimeters of lead apron. but in most cases, usually lead aprons are 0.5 millimeters due to use in fluoroscopy. Protective apparel, thyroid shield, which is shown here. Thyroid shield is another form of protective apparel. Used mainly in fluoro and special procedures, should be a minimum of 0.5 millimeters of lead. Protective eyeglasses. Lens of eye can be protected by use of eyeglasses. 0.35 millimeters of lead found within these lead glasses here. Again, these are wraparounds. Percentage of X-ray attenuation. So 0.25 millimeters of lead. The weight is in kilograms, 5 kilograms. So at 50 kVp, it absorbs 97%, 75 kVp, 66%, and at 100 kVp, 51%. So again, in fluoro, that's what most aprons are. The weight is 3 to 7 kilograms, almost 100% at 50 kVp. At 75 kVp, it's 88% absorption or attenuation, and at 100 kVp, attenuates 75% of the beam. At 1 millimeter thickness, so this is like the lead apron that we place on people's laps. At 50 kVp, it absorbs or attenuates 99%. The weight is 5 to 12 kilograms. At 75 kVp, attenuates 99%, and at 100 kVp, 94%. So of course, the thicker the lead, the more effective it is at attenuating the beam. So again, when you're holding the cassette, try to stand on the side here. Don't stand directly behind the image receptor because you're going to get the primary beam right here. So you should stand at 90 degrees, kind of at the sides here or at the sides here, or like this blurry image right here, where the girl is standing pretty far away on the side, and she's using a grid holder. Pregnant personnel. The pregnant personnel should declare pregnancy and is counseled by the RSO. Second dosimeter, the baby dosimeter, baby monitor is issued. Monthly equivalent dose to embryo fetus does not exceed 0.5 millisieverts. 0.5 millimeters of lead aprons should be worn. Usually wraparound protective aprons are preferred. Pregnant personnel does not necessarily need to have a reassigned work schedule, so they should be able to do everything that a regular tech does. Cardinal rules: time, distance, and shielding. Distance using the inverse square law. Structural shielding. Primary protective barrier to prevent radiation from reaching those on the other side of barrier consists of 1.6 millimeters or 1/16 inch of lead, extends 2.1 meters or 7 feet up from the floor. Primary barrier is where the tube is facing. Secondary barrier is where the control panel is. Structural shielding. Second radiation protective barrier protects against leakage and scatter radiation. Any wall or barrier not struck by radiation should overlap primary barrier. Consists of 0.8 millimeters or 1/32 inch of lead. Extends to the ceiling past primary barrier over 2.1 meters or 7 feet high. Structural shielding. So there's the control booth barrier right over here. Protects the radiographer. Extends at least 2.1 meters or 7 feet upwards from the floor to the ceiling. Permanently secured to the floor. Usually X-ray scatters 2 times before reaching this barrier. Control booth barrier should only intercept leakage and scatter radiation, so that's why it's called a secondary protective barrier. Lead glass window in booth allows for radiographer to visualize patient. The leaded glass window consists of 1.5 millimeters of lead. Extends upwards again 2.1 meters or 7 feet from the floor. Rules for lead aprons and gloves. If hands are in the primary beam, leaded gloves should be used, but we never see anybody ever actually wear them. At 100 kVp, an apron must be at least 0.25 millimeters thickness of lead. A 0.5 millimeter lead is most widely used at recommended thickness in diagnostic imaging, especially fluoro. To protect yourself from scattered radiation during fluoro, stand as far away from the patient as practicable. Move closer to the patient only when assistance is required. 0.5 millimeters lead must be worn during fluoro. Lead gloves of at least 0.25 millimeters of lead should be worn. Thyroid shield of 0.5 millimeters of lead are minimum. Remote-controlled fluoroscopy systems. New units that provide best radiation protection are the remote-control ones. Radiologists and radiologic technologists can be outside the fluoro room and behind a protective barrier while operating the fluoro machinery. Protective curtain, sliding panel, intercepts scattered radiation above the tabletop, most beneficial. Minimum of 0.25 millimeters of lead between fluoroscopy and patient, or radiologist and patient. Bucky slot cover is right here. It's at least 0.25 millimeters of lead. So as you slide the image receptor down towards the feet, this Bucky slot cover folds from inside and covers this area right here. It protects radiographer and radiologist at gonadal level. Checkpoint or summary slide, again, primary barrier, 1.6 millimeters of lead, 1/16 inch, 7 feet at 2.1 meters height. Secondary barrier, 0.8 millimeters at 1/32 inch, 7 feet at 2.1 meters of height as well. Control booth, 0.8 millimeters because it's a secondary barrier, 1/32 inch of lead thickness, 7 feet tall, 2.1 meters. Leaded glass inside the control booth, 1.5 millimeters of lead, again within the 7 feet to 2.1 meters from floor to ceiling. Leaded aprons, 0.25 millimeters are the minimum state requirement. Thyroid shield, 0.5 millimeters lead equivalent thickness. Leaded gloves, 0.25 millimeters protective curtain. On the machinery is 0.25, and the Bucky slot cover is 0.25 millimeters of lead. Protection during mobile examinations. Wear leaded aprons should be found on every portable machine. Distance, stand at least 6 feet, 2 meters away from the patient, from the x-ray tube, and from the beam. Stand 90 degrees from patient. So as pictured, here's the x-ray tube shooting towards the patient, and you should be standing where this letter A is. Try not to be standing where letter B is or where letter C is. Most of the radiation is going back towards the tube, or like what we call backscatter, not towards A at 90 degrees. Protection during surgery. Shielding worn by everyone in the room. 0.5 millimeters of lead for neck and apron should be used. Sometimes a lead acrylic portable shield can be used for like surgeons to stand behind or vendors. Use of foot pedal or handheld is advised. Image intensifier here usually has lead in there as well, so that acts as a barrier. X-ray tube shoots across here. There's high backscatter from this area here, low scatter on this side here. X-ray tube should be placed under table. Image intensifier placed above. So this image intensifier should be above the patient when you're shooting APs, and this part here should be below the table. Collimate beam to smallest area possible. Again, from the tube, you're going to have high backscatter, and then once it gets through the patient, there should be low scatter after that. Radiation signage, again, this is a regulation. You must have a X-ray beam on sign. States require indication of when the X-ray beam is on. Some even require exposure to terminate if door is open. So I believe the only place I've seen this at is actually at St. Luke's in the Phillips room, that if the door is open, it will not take an exposure. General signs should be displayed where areas of radiation are found. A radiation area is deemed a place where 0.05 millisieverts in 1 hour of radiation occurs, so basically almost any X-ray room. Radioisotopes and nuclear medicine. Atoms with same number of protons but different number of neutrons are called isotopes. Isotopes that change to rectify this unbalance to achieve lower states of energy are called radioisotopes or radionuclides. Nuclear medicine uses these radioisotopes, radionuclides called radiopharmaceuticals, when used in nuclear medicine. The half-life of the radiopharmaceutical, time for radioactivity to decay, is captured by a gamma camera to detect abnormalities. Radioisotopes in nuclear medicine continued. Common radionuclides used in nuclear medicine are Tech-99, has a half-life of 6 hours. Diagnostic use has many organs. Iodine has a half-life of 8 days and is used mainly for the thyroid. You can inject it, ingest it, or inhale it for nuclear medicine. Disposal of radioisotopes and items that have been contaminated should be detailed within a radioactive safety program. Must wear gloves if isotope is in liquid form. Never touch radioisotopes by hand. Equipped with personnel dosimeters, follow cardinal rules of radiation protection. Some procedures will require isotopes to be returned to shielded containers. Content should be labeled with how much activity remains in the current date, that should say container, will be held for a period of 10 half-lives before the isotope can be disposed in regular trash. All right, and that is the end of this lecture. It's been a great semester. Thanks, guys.